Hello, everyone. Welcome to Changing the Narrative webinar series. My name is Zachary Siegel, and I'm playing host today. And if you're listening to this after the fact, we are recording live and we have a few listeners. What we'll be doing moving forward is giving much more time between them and promoting them much more. That way we can have a more uh, lively event. But if you're listening to this after the fact, thanks for tuning in. We have a very special segment prepared for today, and we will be hearing from a CTN original co-founder, Kate Nicholson, who has been influential in helping us draft and target media narratives in the realm of prescription opioids, policies regulating prescription opioids, particularly at the federal level, at places like the CDC that will get into their guidelines and all these things. So there's a lot of information, and this is a very nuanced subject that the media has not always risen to the occasion to adequately convey. So, without further ado, Kate Nicholson, thank you so much for being here.
Thanks, Zach. I'm delighted to be here.
Great. So, a bit of background about you before we get started. I mean, you are a civil rights attorney. How did you first get into the prescription pain and chronic pain space? What led you to this road first?
Well, actually, my background, sort of both my professional and personal background led me to this space. As you noted, I'm a civil rights attorney. I actually spent most of my career in the Civil Rights Division of the Justice Department, doing a lot of health-related civil rights law, particularly under the Americans with Disabilities Act. I brought some of the early HIV/AIDS cases about discrimination in healthcare. So this is an area of passion for me, both ensuring that people have a right to healthcare, but also operating within what we call public health crises. But it's also a very personal area for me. One day when I was working at my desk at the Department of Justice, my back started to burn really badly. It felt like acid was eating away at my spine. And pretty quickly, my muscles seized and tossed me right out of my chair onto the floor. And after that, I actually couldn't sit or stand or walk for the next 15 years. It turned out it was related to a surgery where a doctor had severed part of my spinal cord, but the symptoms only appeared when the nerves started to grow back and scarring and adhesions formed that caused a lot of problems for me. I tried for 3 years about 37 different kinds of treatment, different medications, different alternative treatments, and some very invasive procedures, including a repeat surgery to try and repair the issue, but that proved ineffective. And so when my physicians ran out of options, they suggested that I try opioids, and I had avoided them for that time. I was sort of afraid of them. But they really helped me. They enabled me to continue to work and function despite very difficult circumstances. I still had to argue cases from a reclining folding lawn chair and supervise cases from a video teleconference screen, but I was able to have a career under really difficult circumstances. And then many years later, surgical techniques improved, and medical devices and a variety of things led me to start to be able to walk again. And when that happened, I went off of the opioids without any difficulty. I was appropriately tapered by my physicians. But one sort of final thing happened that brought me into this conversation. I had moved from Washington to Colorado to Boulder So I was in a new medical community, and I went into the doctor one day, and this was when I had already started to taper down. And my physician said, I'm not going to prescribe opioids anymore, and you won't find anyone else in the area who's willing to either. And what had happened is that a local and very well-respected physician had prescribed to a DEA enforcement agent who had posed as a pain patient, and that sent shockwaves through the local medical community. So, in fact, I asked her if she'd just give me the rest of a taper plan and prescribe for another month or so, and she was not willing to do that. So I was able to fly back to my own treatment team in DC and get an appropriate taper plan, but it did give me a sense of what was coming for pain patients in the environment. That was in 2014, before before some of the laws and policies that we're going to discuss were really ramping up.
Wow.
So
I mean,
that's how I came in. Yeah.
that is incredible that, even back then you were sort of seeing sort of what was to come, and we can get into what that looks like more. But I wanted to go back to something you said that you had been avoiding opioids while experiencing this terrible pain and, through no fault of your own, uh, sort of befell onto you. And this, I think, notion is really important to highlight is that most people who are on opioids or have complicated medical problems that lead them to opioids, like probably would rather not be on them and would rather not have these problems to begin with, right? Because it's like this, very much was a huge issue for uh, your whole career, but like the one thing that helped you had some semblance of quality of life was opioids. I just wanted to highlight that like really, people would rather not be on these things.
Right, if you don't have to. I mean, there's sort of when you're in a really difficult circumstance and when people have serious disabilities or multiple comorbid conditions in which, sort of nothing else provides relief. They can be absolutely necessary medication, and very helpful medication. But yes, of course, this is not a situation in which most people are seeking them out because of the euphoric effects. It's generally a situation in which people don't have other options.
And so one thing to sort of set the table here for a larger conversation is that basically uh, the narrative that has been created and affixed to the current overdose crisis is largely one that goes something like there was massive overprescribing of opioids, and way too many people had been exposed to them through their prescriber. And this, back in the 90s and early 2000s, ignited what's been called the first wave of overdoses, where, um, you know, way too much OxyContin, way too much oxycodone, and hydromorphone and oxymorphone. All these pills were being prescribed in a very sort of in a new way that doctors hadn't been doing before. And so to this day, prescription opioids are very much described in reporting and journalism as a dangerous substance, as an addictive substance, as something that caused this horrific wave of overdoses. And I wanted to hear your take on this sort of first wave and how prescription opioids are conveyed in the media.
Right. Well, I think that the issue with the narrative is that there are kernels of truth in all of it. It's just a very narrow story. We know that prescribing certainly became more liberal in the 90s. It was the 90s when my pain started, and my doctors weren't certainly rushing to prescribe opioids to me, but there was definitely a liberalization of prescribing and an idea that pain was undertreated, particularly chronic pain. And so it is certainly the case that more, I think, primary care physicians all over the country, maybe people who were not pain management specialists, began prescribing more opioids. So that created a larger supply. I mean, we know from a lot of the surveys on drug use and health that most people who misuse opioids did not get them directly from a doctor. They got them from a family member or a friend, or from bought them on the street. So there is a little bit of a conflation of, um, this idea that it's all pain patients who are suddenly becoming addicted, which is not necessarily true. I mean, certainly, pain and addiction are sort of separate entities, and human beings being what we are, they sometimes can coexist in the same person. But I think there is this very persistent narrative that it's mostly people with chronic pain who were prescribed opioids who then became sort of forever addicted to them and lost their lives. And that is, at least the research shows, largely untrue. There is certainly a risk with exposure to opioids of addiction, and that risk can increase with long-term use, but it is still a relatively small risk on a relatively low percentage of people. So,
Right.
I mean, the diversion issue was real. The idea that there was more supply there was real. I just think it's very important to sort of separate out, because these are really complicated questions. I mean, when I was a patient, my doctor very carefully screened me before starting me on opioids. I actually had psychological screening where they looked at sort of, my history of drug use, my history of alcohol use, my family history, all of those kinds of things, my psychological history, and to decide whether I was a good candidate. And I think part of what happened in sort of more liberal prescribing is some of those necessary sort of screening tools were not necessarily utilized. But it's a complicated story. I just think it's
And
important.
yeah, and
Go
and
ahead.
and and back into the way that this complicated story gets told in journalism, which is, what I read a lot of, and I'm a quote unquote member of the press who has been
Yes.
contributing to this space. And one thing I see in a lot of my colleagues is reporting on the subject is that the story begins at the moment of a prescription. Oftentimes,
Right.
if it's Johnny, the football player, broke his ankle and was prescribed 60 Vicodin over the course of a couple months, and then 6 months later died of a heroin overdose, like that's a very stark and horrific trajectory for a young person to be on. Um, but one thing that I think is always missing is what in life preceded that prescription. People don't go into doctors' offices blank slates. There are, like you're saying, screening tools that can
Right.
help us understand vulnerabilities in certain people who, if they take an opioid and they begin to feel not just that their pain physically is being relieved, but that emotionally they're suddenly not depressed, and that they have energy, and that they feel better, and that life is suddenly a much more pleasant experience. That gets into a whole other realm of complicated uh, terrain that requires a lot of nuance. And can you sort of talk about first the some of those vulnerabilities that you were screened for, like you mentioned prior drug use and things like
Right.
that, but and also psychological things. Can you so like um, in the sort of first wave of this crisis that we're talking about, the so many people, um, you know, maybe weren't screened or weren't
Right.
being properly vetted before getting way too many opioids handed to them.
Absolutely. I mean, there's a lot packed into that particular story. We do know that not everyone is at, even though addiction can happen to anyone, certainly, not everyone is at equal risk. One factor that's high risk in the scenario that you described is age. I mean, young people are definitely at, when their brains are still forming and patterning, are at greater risk. But beyond that, we also know from drug use surveys that most of the people who misuse prescription opioids had prior drug had experimented with other drugs, and not just alcohol or marijuana, drugs as potent as methamphetamines or cocaine. And so sometimes there is prior drug history. That's one of the things that's screened for. In terms of mental health, I think for me, I was one of, and this is complicated with chronic pain because some people with chronic pain do develop depression and anxiety. I wasn't one of them. I was fortunate just by brain chemistry for that not to happen. And your sort of life circumstances, health circumstances. So there's the screening before, but then there's also the follow-up after, which is really important as well, which you mentioned, with people sort of liking how they feel on this medication, not because it is helping with their mitigate their physical pain, but it is addressing their emotional pain or their sense of belonging or their sense of, self in the world. And it's really important that a physician not only screen, but also participate in sort of ongoing monitoring and ask the right questions to make sure that someone is in fact, using the medication for the purpose for which it is prescribed. And I do think that medication management in general is sort of a lost art. It is increasingly a lost art in the hostile regulatory environment that we see. But I think even in the 90s and going into it, once we understated or the addictive properties of opioids, and primary care doctors and other clinicians were prescribing them more readily, I'm not sure those sort of screening and monitoring techniques were followed for a lot of people. And several people. I wrote an op-ed with Ryan Hampton, who is someone who was prescribed an opioid and ended up using heroin, because I think it is important to show that there are both sides of this pill, this medication, and that there are risks, but there are also benefits. And he was pretty frank that it helped his ankle for a minute, but it was really the way it made him feel that led him to continue using. So I think, if people were more honest about their stories and experiences, we might see a different story. But the narrative we hear is a very simple one, where there's an evil villain of big pharma and the sort of duped population of physicians and the very innocent victim. And as part of the appeal of that was to avoid sort of the stigma that attaches to addiction, that wrongly attaches to addiction. If someone is considered an innocent, we have sympathy in a way that we seem not to when someone is, in fact, using because they are suffering emotionally. So it's complicated. It definitely
Yes,
is.
and I see this often either in sort of like the Purdue Pharma defense, like of themselves in their press releases, that it's the quote drug abusers who are the
Right.
problem, and that it's not the patients. And there's this very stigmatizing lens used by, cynically, I would say, used by companies that are trying to defend themselves and saying that these are people acting illegally and they're drug abusers and they're the problem. And in, the discourse on Twitter, and we don't have to belabor this, but there are people who carry that as patients who have been tapered or forcibly removed from their sort of care that was helping them, and then they also blame the quote drug abusers for ruining their medical care. So that we get into this, I think, very stigmatizing and often circuitous argument about the who ruined it for who and all these things. And I think some of that shows up in the media, but mostly it's just coming from the Purdue Pharma press releases and uh, the sort of Richard Sacklers of the world who will blame drug abusers. And it's like I think that's a false premise and that we don't really have to engage it, but just to say that it is out there. And part of what's great about changing the narrative is that we have uh, several patients who work alongside people in recovery or with histories of addiction, like Maya Solovitz and Brooke Feldman, where
Right.
we have found a bridge that patients have a lot in common with the recovery community. Both are stigmatized in their own unique way that winds up at the same endpoint with bad healthcare.
Absolutely, absolutely. And that was really the reason that Ryan and I decided to write the op-ed we did, because there was this hashtag going around Twitter called Patients Not Addicts. And we felt like we were just basically cannibalizing each other. I mean, really, it's the people on both sides of this swing on liberal and then sort of arbitrary constrained prescribing, people who became addicted, and people who are in pain, who are being arbitrarily cut off of their medications, who are the victims of both swings. And instead of sort of seeing what we have in common, there can be this infighting that I agree with you is coming from those who were in power and had influence over how all of this happened, and not from the communities of individuals who have been harmed. And the thing that I find so tragic about it is that, um, it keeps all of us down. It brings all of us down. And these stigmas are now bootstrapping on each other. I mean, pain has lots of stigmas too. Most people don't understand the difference between sort of acute pain, which is a normal body function. If people who have genes that make them unable to feel pain don't live very long. We have to know to rest or bandage a wound. But when that acute pain is severe, people don't heal well if they're not treated adequately. And when that acute pain becomes chronic, whether because of an underlying chronic condition or just acute pain that becomes a chronic pain condition, the pain loses that protective function and behaves more like a disease. It actually damages every body system, and that's why it's really important to treat it. But there's a lot of misunderstanding about pain. People think we always have pain. We've always had pain. We always will have pain. That everybody can just buck up. There's a lot of discrimination in the disability community against people who have incurable conditions, and certainly, a whole wealth of background from our religious traditions that suggest that pain is something that should be born, that that's what builds character and gives us joy, and whether that's sort of the version of um, pain in the 19th century that meant that anesthesia wasn't used for about 100 years after it was discovered because God meant we should feel pain, to sort of the current version that we see in the Marianne Williamson, the current Democratic candidates, talking about, sickness is an illusion, and pain being necessary for joy, and all of that, which again have kernels of truth, but really understate the comprehension of a very serious disease. I mean, people with moderate to severe chronic pain have a quality of life index. This is something that doctors sort of can measure the quality of one's life, meaning can you participate in work? Can you carry your kids around or wash dishes? And the quality of life index for someone with moderate to severe chronic pain is the same as that of someone who is in late stage or dying of cancer. So, these are serious conditions that need to be treated. And then now you have all of the stigmas about addiction, which don't understand it as a disease, don't understand that people have different vulnerabilities to it, and instead blame the user and see it as sort of a moral failing on either side, a moral failing because you can't cope with your pain, or a moral failing because you're using a substance to cope with your pain, your emotional pain. Um, these are sort of bootstrapping on each other and dragging us all down. And that is one of the wonderful things about this group is our, conversations and attempt to sort of break these simple stigmas and tropes down because we know there's a sort of rich tradition and scholarship that shows us that stigma itself is a major determinant of barriers to healthcare and barriers to participation in society.
Yes, and I think one thing that we all agree on here is that the stigma and the barriers you're just mentioning they do creep into journalism and media depictions of this problem, and that's how we get these very simplistic stories that while there are a few kernels of truth here and there, really miss the forest for the trees, and that
Yeah.
this then filters to the realm of policy and laws. And this is where I think the conversation gets, the stakes become even higher, is that out of the narrative that prescription opioids on their own caused this terrible crisis of overdoses, we now see the policy response. And I was wondering if you could sort of break down where that has gone. And I'm thinking about pill limits and all sorts of things that are translating guidelines and measures to improve prescribing into law.
Yeah, there has been an attempt by anytime we're in an environment of sort of stigma and fear, where in some sense, public health authorities were caught flat-footed. I mean, we ignored overdose deaths for far too long in this country. Our public health authorities did. There has been a very sort of quick and dirty and rapid uptake of laws and policies trying to contain um, the overdose crisis by putting limits on prescribing. So the theory was that it was liberal prescribing that caused all this, and we can put the genie back in the bottle if we just take the prescriptions back. And what's happened with that, I mean, it really there was media pressure and some general policy pressure. Prescribing really started to drop precipitously in 2012. So we're currently already at, like, according to the FDA, at a 15-year low in terms of the number of prescriptions filled at retail pharmacies. There may still be some regional areas where prescribing is higher, but basically, even aside from the uptick in laws and policies we're going to talk about, prescribing started to drop around 2012. But what happened in 2016, the Centers for Disease Control and Prevention issued guidelines, and they were guidelines designed, they were targeted at primary care doctors, not pain management physicians, but primary care physicians. And the reason they were targeted at primary care physicians is that lots and lots and lots of studies show that pain, surprisingly to most people, because it's second only to the common cold for why people go to the doctor, is not really covered in medical education. There is just a glaring discrepancy between the prevalence of pain in society, where we have 50 million Americans in daily or near daily pain, 40 million in severe pain, and 20 million in disabling pain. But I think a Johns Hopkins study in 2011 found that only 4 U.S. medical schools had a single required course on how to treat pain. So pain isn't really part of the primary care curriculum. If there are physicians who go on to specialize in pain management who get more training, but that's not true of most primary care clinicians. And so the CDC decided to issue guidance to primary care clinicians about how you should appropriately prescribe opioids when you're prescribing to people with chronic pain. And a lot of what's in the guideline is non-controversial and makes sense. They said, opioids shouldn't be the first line of treatment that you provide. You should try other more conservative treatments first. I mean, one of the problems is that a lot of those conservative treatments aren't covered by insurance. But nevertheless, it's part of why doctors prescribe. That's the other part of why doctors prescribed pills pretty readily. But nevertheless, the CDC said, don't use this as a first line of treatment. And if you are going to start someone, start at the lowest possible dose for the shortest possible period of time that's effective for that person. And so none of that, again, is very controversial. But there were a couple things in the guidelines a couple places where numbers appeared, and policymakers have sort of seized on those numbers. One area was a single sentence in a guideline about chronic pain prescribing that dealt with acute pain prescribing. And it was one sentence, and it said, that you're not often going to need more than a 3 to 7 day supply for most acute pain. It was also right on the face of the guideline, given the lowest possible evidence quality. The CDC said, evidence quality 4, which is very poor evidence quality, where the result is likely to be very different from what the studies say. But nevertheless, it was in the guideline as sort of a flexible, thumbnail for doctors to follow. And the other place was the CDC said, when you're starting a new patient on opioids, be careful going over 50 MMEs, which is morphine equivalent units, and justify if you're going over 90. So that was how, try to train primary care doctors on how to start somebody who's never been exposed before to opioids. But what's happened is that since that time, pharmacies, insurance companies, quality control metrics, many state legislatures have all sort of lifted aspects of some of those numbers and enforced them as hard and fast rules. So I think, with respect to the dosage guidance I talked about, and I know this is getting a little in the weeds, but it's the area that's causing the most problem for people who are long-term opioid users in this country. The CDC never intended for it to be applied to people who are already taking opioids long-term, but that's exactly what happened. So, for example, Human Rights Watch did a report that showed that doctors were just using those numbers and sort of taking their patients down to those doses, even if they'd been on higher doses. And it sort of was interpreted as a benchmark or a safe prescribing zone that would keep them sort of out of the snares of law enforcement, because U.S. attorneys' offices all over the country are also using those dosage guidelines to sort of send letters to doctors, as our state medical boards, saying you have one patient over this MMA, stop. So
Yes, I would definitely want to get into the DOJ and DEA sort of surveillance and the whole PDMP aspect of this in just a second. And one thing I wanted to mention is this just like one-size-fits-all policy making for something very complex and individual, which is, people's experience of pain and how doctors treat it, and to put millions of people in this arbitrary 50 MME to 90 MME sort of range, and then box them in there, and then apply pressure to doctors to keep them boxed in there, just seems like a disaster on so many levels. But maybe we could use the state of Oregon as one particular illustration that took this to the nth degree and tried to, I believe, just eradicate opioid prescribing from medicine outright.
Right. Yeah. So there was I actually worked on that, on trying to get Oregon basically promulgated a policy that they put out in which they were going to initially, as they put it, that they were going to forcibly taper everyone with chronic pain off of their opioid medication who was on Medicaid. So it was affecting, over 100,000 people, regardless of their underlying condition, and in a state where they didn't really have any protocols about how they were going to do this. So, and it took us a year to get them to change their policy. And part of the reason they did was because some of us also met with the CDC to ask them to clarify that their guidelines were being misapplied by policymakers, which they did. And the FDA also came out against forced tapering or abrupt tapering of people from their opioid pain medication. So yeah, I mean, Oregon decided and it was sort of in some ways a good, like many of these policies, a well-intended idea gone horribly wrong, because what they were going to do was cover a broader base of treatments under Medicaid, but the condition of doing that meant that everyone had to be forcibly taken off of their opioids. And that's very problematic for people who have taken them in many cases for decades. It's not a simple question how one deprescribes in that situation. So there have been a lot of terrible policies. And even in the day limits, they just keep popping up. I mean, even after the CDC clarified, the Trump administration announced last week that they were going to put strict limits on prescribing for federal employees under the federal employee benefits plans. And Rob Portman is again floating a national 3-day limit. Senators Gillibrand and Gardner had floated a 7-day limit. Then that's for everybody. Regardless for acute, that's really targeted at acute pain prescribing, but for anyone, regardless of whether they had, sort of a sprained ankle or a double hip replacement. So it is these sort of one size fits all limits just in general when you're looking at huge categories of even acute pain, which can range dramatically, but also chronic pain, which can come from, MS. It can come from sort of nerve damage or neuropathic conditions. It can come from inflammatory or autoimmune conditions. So just it's a very broad category that includes lots of different kinds of pain, lots of different kinds of conditions. And one of the things that the CDC also had to sort of and take note of was the fact that even though its guidelines were not intended to apply to people with cancer or people with sickle cell, it was also affecting cancer patients who were unable to get their medication. So the corrective has been swift. I mean, I think we have more than 34 states now with laws on the books. It's happened incredibly rapidly. It's been happening at a time when prescribing was already dropping precipitously, and it's doing a lot of damage to people. I hear from people every day who have lost their ability to work and function, who are bedridden, who have to take disability or are financially devastated. I hear from families who've lost loved ones whose medication was abruptly stopped or even stopped over a period of time, and they either committed suicide or turned to the street market, which, as we all know, is quite potent and very dangerous today. So it's having, very, very dramatic unintended effects that certainly is not doing anything to protect people from becoming addicted. It's really mostly hurting people who were doing well on their medication and can no longer gain access to that medication.
Yes, and then so what you're talking about, these hard numbers, these metrics that politicians and policymakers seize on, then get filtered back to the media sphere, where reporters can point out that prescriptions fell by, or total MME volume fell by X%, and that led to a Y reduction in opioid overdose deaths, but only mentioning that the prescription opioid overdose deaths had declined, and those had been growing very slowly, more gradually, and then started to decline. But they're not mentioning the huge increases in heroin and illicit fentanyl deaths, and so there's this way that these numbers get reported as wins in media, but the context is very much absent, and so this sort of the quantification of the problem is very alluring. But it is, like you're saying, not measuring patient suicides and not taking into account other opioids that people might, or markets that people might have been pushed to that are far more dangerous and deadly. And so this problem just seems to have an infinite list of unintended consequences that can be conveniently not looked at. And so that's another huge component to the narrative, that there's so much context and so many different things one must look at in order to get a full picture. And so I did want to change gears a little bit in the end here to talk about how the DEA is looking at prescription drug monitoring programs, and this is another area where the quantification of the problem takes center stage, and the human measurements, the quality of life measurements, are take a back seat. And changing the narrative at the Health and Justice Action Lab is doing a lot of work in the PDMP sphere. And can you talk a little bit about PDMPs and talk a little bit about the effects of this kind of surveillance?
Sure. So PDMPs, are prescription drug monitoring programs, now I think officially exist in every state. And they basically are ways in which when a prescription is filled, it's logged into a system. It's very it's very non-contextual information. It's just telling you sort of who the person is and what their excuse me history, who their prescriber is. Sorry. And what their history of which medications they've taken is. So it doesn't tell you, what kind of disease they have or anything like that. So it's a very narrow stream of information. It is a tool like any other. There are pain management physicians who consider it to be a good tool in appropriate pain treatment, because they can look and see if, what medications a person has been on. And by doing that, if someone's forgotten to mention a medication that could have contraindications, they can identify those medications. The problem is that it's really been, it's become an oversight tool. It's been used by law enforcement, by pharmacists who are increasingly in the position of sort of policing prescribing practices, and even by private companies like EPRIS that issues NARC scores, where they're mining this data, and in a non-transparent way. We don't really know which factors they're using because it's a proprietary method. They are flagging people as potential abusers, or as potential opioid overutilizers. And those kinds of flags can exist for a variety of reasons. If someone has seen more than one provider, if someone has gone to more than one pharmacy, or these scoring algorithms that may define someone as an overutilizer. The definition under CARA, the Comprehensive Addiction Recovery Act, is basically if you've had 2 prescriptions for an opioid in a year, you're an overutilizer. Some of the other Medicare and Medicaid data can use different factors. One of the things we found, at least from the initial studies, that a lot of these flags are shown to be not very good indicators of who's likely to actually be misusing their medication. But these are all ways to sort of prevent a patient from prevent a patient from what we call doctor shopping, going from doctor to doctor and trying to get prescription medications, or going from pharmacy to pharmacy to get illegitimate prescriptions filled. And so the problem with all of that is twofold. And I'm talking from the patient perspective here. I'll switch to the provider perspective in a second. Is twofold. One is, in the current environment where pharmacies are denying fills because someone has a flag, or doctors are dropping patients. There was a study recently that showed that 40% of primary care doctors will not see new patients with chronic pain who use opioids. They just won't see them at all. So a lot of patients are being abandoned in care because opioids have become too hot to handle. And so, we're in some ways we're forcing people to go to multiple pharmacies, and we're forcing people to go to different providers. But even in a situation where that isn't the case, there was the former head of the American Medical Association told the story about a patient of hers. She's a cancer doctor. who went to try and fill his prescription, which she had written for him by calling it in. He was in a different region than where she lived, by calling it into a primary care doctor. And the pharmacist said, well, you've got multiple providers. I'm not going to fill your prescription. You're obviously doing this to misuse your medication. And the guy went home, and 3 days later, he tried to kill himself. He couldn't really endure the pain he was in. So the problem is we have these sort of checks and oversights at a lot of different levels. Insurance companies are sort of flagging people, using these numbers to flag people. Pharmacists, again, are doing it. And so there are a lot of places at which patients can fall through the cracks. And then switching gears to the providers, PDMPs have sort of become an arm of law enforcement. I think that's a lot of what you guys are working on, in the sense that,
Yes.
in the sense that the Drug Enforcement Agency, which has been just arbitrarily, talk about arbitrary limits, has arbitrarily been cutting the opioid supply every year. They have like a 3-year goal just to cut it down, which has led to some serious problems of us, hospital shortages of opioids and things like that. In part, it was partly manufacturing problems, but also because of some of their actions. But they are using this PDMP data as a way of targeting prescribers. And they're saying, either, you have too many patients on opioids, or you have, without really looking at the context of whether they're pain doctors or cancer doctors, or, treating a particularly beleaguered population, or looking at the dosages they're prescribing and sending them letters or initiating investigations based on that information. And I mentioned that U.S. attorneys' offices are also sending letters out to prescribers, just from sort of policing the PDMP data. So it's we're getting crunched on both sides. It's happening with with respect to drug enforcement, and it's happening with respect to sort of how patients are being flagged. So both providers and patients are being flagged. Both are being put under pressure. And I would argue when you flag providers like that, you're really just turning patients into liability. So it's not terribly surprising that nobody wants to see chronic pain patients anymore. But that can't be a good outcome of the healthcare system or our laws and policies.
Right. And I think everything you just laid out very much ties neatly into the whole theme of changing the narrative and this webinar in particular, because the narrative that everyone sort of takes up in media filters to the politicians and filters into the policymakers and people who are simply reacting to the soaring numbers of prescriptions, and that some pharmacy in West Virginia got millions of pills, and these stories that are very much driven by there are huge quantities of prescriptions and this is causing problems, and if we contain and reduce the prescriptions, well, that'll get us back to a steady level of overdose deaths, and hopefully we see reductions. But like you mentioned moments ago, since 2011, since 2012, there were reductions in prescribing, and this has been ongoing. This has been a trend happening for over 5 years now. And all that has gotten that we know of per preliminary CDC data for 2018 deaths is maybe a 5% reduction in deaths. And I think this is just so important to highlight, is that just because we can measure and quantify the MMEs and the total volume of pills and where the pills went and in what area, does not mean that cutting those down is going to get the outcomes we're looking for. And I think
Right.
Opening the space for that context and that nuance is exactly what we're trying to do with this conversation and trying to do with changing the narrative. Because if we have a simplistic view of the problem, we're going to get simplistic solutions that don't get us to where we want to be.
Absolutely. And if you're just looking at cutting MMEs, the fastest way to do that is to take the people on the higher doses who often have the most, sort of multiple comorbid conditions down on their dosages. So, what we've also seen is if you graph the way in which overdose deaths have risen since 2012, escalated really in the last 5 to 7 years, just dramatically. And you look at the graph of how prescribing has dropped, they actually form a perfect X in the sense that prescribing has dropped precipitously at the same time that overdoses have escalated dramatically. So something has definitely gone awry in our policy choices. We are not really solving the problem. Certainly.
And so we're wrapping up. We're pretty much at the hour here, and I just really wanted to say thank you, Kate, for coming on and for being a smart, passionate, caring voice in this space, because there is just so much stigma, so much misinformation, so many simplistic narratives that really win the day. And I think when that happens, we do see the policies that we're getting, which might sound good to lay people or might make constituents feel better that there's something going on and that people are doing something. But when we take a few steps back and look at where we're at, things are still very much, like you said, awry. We have a lot more work to do. And I think by changing the narrative, by injecting all this nuance and complicating the dominant narratives, we can hopefully get more complicated, or rather, solutions that are calibrated to the complexity of the problem at hand.
Absolutely. And thank you for all the work that you did to put this together, Zach. The website and everything in terms of combining our efforts. It's just been extraordinary and very helpful.
Yes, obviously, if anyone out there is listening and you see a friend, a family member, or a newspaper writer, or an editorial board, anyone who is saying the wrong thing and broadcasting that out to many, many people, send them our way, send them the website. We just put out a style guide to help reporters sort of better situate where prescribing plays a role in the story, and to better, to get better interviewing and better stories out there. So I really do hope that by all of us working together, we can, I think, just let things be complicated and let this problem be looked at in a much more compassionate and, frankly, like scientific way.
Absolutely.
Okay. Thanks again, Kate.
My pleasure. Good to talk to you as always.